Jim Ekman Festschrift. This is a day long overdue to honor and recognize one of Emory's most impactful faculty members, Jim Ekman. We'll talk a little bit more about Jim. Essentially is on anyone's who's who of the world leaders in sickle cell disease. And last September 1st, he became Professor Emeritus, meaning that he will now be working 6 days a week instead of 7 days a week. Some weeks, other days it's back to 7. So to kick this symposium off, we thought there would be no one more appropriate than our Dean, Chris Larson, and our Executive Associate Dean for Education, Bill Ely, who have long friendships and associations with Jim. So, Chris, welcome and thank you.
Thanks, Fadlo. It is my pleasure and honor to welcome you here for this symposium to celebrate and thank Jim for his extraordinary career here and just the impact you've had on the lives of so many thousands of patients, directly and indirectly. I remember you as a student. I remember you teaching me how to work up anemia and a little bit about sickle cell anemia. It must not have stuck, really sunk in because I became a surgeon. I remember you as a resident. Although the blinders were on and all I could see what was in front of me. But I remember you as a transplant surgeon working with Tony Gouache and our transplant team. And really, your extraordinary expertise and dedication and kindness in helping us develop protocols to transplant patients with sickle cell anemia. So I remember you as a wise and generous physician leader. But mostly I remember you and thank you from the vantage point of somebody in a different part of the institution, but for your just dedication and devotion and the choices you made over the course of your career. The choice to stay and develop and lead a program to really revolutionize the way sickle cell anemia was treated and care should be delivered. I remember you as just a great educator and role model for so many students and residents, and I'm sure fellows. And not only in the way you modeled it, but I'm sure the impact that you've had on the thousands and tens of thousands of lives that they've cared for in the ways that you've taught them. So it's just wonderful that we get together here and share knowledge, connect with old friends, but mostly to celebrate and thank you for your career. So I thank you as the dean, but I also thank you for a few deans before me who also thank you for their service. So with that, I'll ask Bill Ely to come.
Good morning, everyone. Thank you for being here. It's truly an honor to be up here in front of a person who I will call a mentor. 1981, September, I walked into my first internal medicine rotation at Grady Hospital. My resident was Andre Churchwell, who's now a cardiologist and dean at Vanderbilt, and my attending was Jim Ekman. And boy, did I not know what I was getting into. What I got into was a master at the bedside. Jim was incredibly professional, incredibly insightful about patients in their social context, and went even beyond that to teaching us about the physical exam, especially about medical reasoning. He has impeccable logic when it comes to caring for patients. He has dedication to follow up on the most minute detail. I thought about that. All of us have obsessive characteristics. We know that. And then I thought about Jim growing up in Minnesota. He grew up in a place where if you forgot your mittens, you lost your fingers. So I tell all our medical students as we train them, we want them to be just the right amount of obsessive when they're taking care of patients. It's a characteristic of a great physician. And Jim Ekman certainly demonstrated that in that month of medicine I spent with him. He had a natural sense of clinical epidemiology that I think just came to him intuitively. He didn't get an MPH as I would later, but he deserves to have one. He knew pharmacokinetics in a way that very few people that I've worked with after that did. I still remember, Jim, your talks about heparin pharmacokinetics and why we should dose it the way we did, and I really think it saved some lives going forward in residency. That I knew that there was a half-life to a drug I was giving IV, and that it should be given deliberately and carefully. I remember your talks about pain medicine, which would come back later, and about how pain medicine should be given rationally, and about how people in pain needed pain medicine. It was sometimes not shared by others in medicine, especially at that time. So that was my first month of internal medicine, and I became an internist. Largely because of people like Jim and Andre, who I said I wanted to be like. I wanted to have that knowledge and be able to help people at the depth that you could and have. Later I was a fellow with Jim. So I got to be a Hem-Onc fellow with him. And we spent countless hours at the bedside, but now with the blood smear. And I only want to say one thing about Jim and the blood smear. I'm pretty sure after thousands and thousands of smears that he is a smear whisperer. That he talks to it and it talks back to him. And I don't know that language. But any of you who've had the joy of working with Jim at the scope know that he can tell you things about the patient that are absolutely stunning. I always thought somebody was telling him ahead of time. But no, I don't think it's true. I think he's just that experienced and has that much wisdom. So as an attending, taking care of people with leukemia at Grady, and lymphoma at Grady, and sickle cell at Grady, and I say that because resources were often strapped, and people came from the most difficult stations in life. Jim has been a shining star. When we revised our curriculum, we made a hematology module, and I didn't know if the great logic of Jim Ekman would carry over to the classroom, to tell you the truth. I knew he was one of the most logical people I'd ever run into. I knew that his paper, The Rational Approach to the Evaluation of Anemia, should be hardwired into all of our minds and would probably reduce the cost of health care nationally by 5 or 10%. But Jim put on that first module and was immediately given a Dean's Teaching Award for his brilliance in the classroom as well as at the bedside and at the scope. So I, like Dean Larson, will say, finally, what's really the measure of Jim Ekman is the way he chose to spend his life. He chose to spend it at Grady. He chose to spend it with people that school us on our biases as physicians and human beings. That he overcame on a daily basis and demonstrated to us what it was like to be a true physician and see through our biases and deliver outstanding care. Aristotle, who I'm fond to quote, said when he talked about measurement, he said there are things that can only be measured by a feeling you get when in the room with somebody. And Aristotle called these people of measure, so that when we're around them, we feel like we want to be them, be like them. So it is with the greatest honor that I welcome you today for this man of great measure, James Ekman.
I always have to make sure my cell phone is off, because I noticed about 12 years ago it really irritates Jim when the cell phone goes off when he's talking. So I'm going to ask Dr. Ruth O'Regan to join me. So I met Jim almost 12 years ago, and it was interesting because before I met him, I was tasked with our then Cancer Center Director, Jonathan Simons, to figure out what to do about what he called benign hematology. So he said, well, before you do anything, I think you should meet the two faculty this would affect the most, Jim Ekman and Sid Stein. So I said, the Jim Ekman? He said, yeah. He said, why? I said, well, Jonathan, obviously you don't know much about hematology, do you? And he said, well, if it's leukemia. And I said, okay. So Jim Ekman really, and Sid Stein, have formed the basis of the classical hematology division, along with Lee Winton and Tom Hefner, for several decades. Jim fortunately stayed in the division and then the Department of Medical Oncology. We were able to work out an agreement with Wayne Alexander, the chair of medicine, which was, rather than negotiate about hematology services, Wayne and I got to discuss a cell paper of his, and that was what he extracted in exchange for our keeping hematology with medical oncology. Worked out for Wayne, and it certainly worked out for us. Jim has been really one of the monumental leaders. Ruth and I can't possibly cover everything that he's done. His CV is 45 pages, but CVs are not in weight. I've seen people who have CVs of 100 pages who couldn't really even begin to describe the impact of Jim Ekman, not just on Georgia, on sickle cell, but on the field of hematology. So we put together a few slides. As everyone knows, Jim is a native Minnesotan and a great fly fisherman. He went to medical school and trained at the University of Minnesota. In 1978, after starting his academic career on faculty at the University of Minnesota, he came down to Georgia, and he previously has been professor of medicine, adjunct professor of pediatrics and human genetics at the Emory University School of Medicine. He's been director of the fellowship. He's been chief of hematology and medical oncology at Grady. But probably, as you're about to hear from Allan Platt, by far his most important work has been establishing the National Sickle Center at Grady Memorial Hospital in 1984, following intensive state lobbying. He's been medical director of the world's first 24-hour comprehensive acute care sickle center, the Georgia Comprehensive Sickle Center, which provides care for more than 1,300 active and 2,500 registered adult patients with sickle cell disease. This is an enormous task. I remember being a resident and not giving a sickle cell disease patient enough pain medication and being told by my attending at the time at the Boston City Hospital, Mark Brower, "You're lucky Jim Ekman is not your attending." So he has established guidelines and impacted quality of life and prolonged life for a generation of patients with sickle cell disease in the Southeast. He's been equally impactful for the young. He's been a champion of screening for sickle cell disease in newborns in Georgia and other states. He's reached out and worked closely with a number of our leaders, including Clint and Peter and Bill Woods, over decades to champion a more integrated sickle cell program and save the lives of many children with sickle cell disease from pneumococcal sepsis through screening and oral penicillin prophylaxis. For this, despite the fact that he's cared for some of the most unfortunate and underprivileged, he's been serially recognized as a top doctor by Castle Connolly. And it's hard for me to think of any top doctor allocation or honor that doesn't include Jim Ekman. He truly is what the profession is about, an inspiring physician and leader. In fact, one of my greatest honors was the one weekend he allowed me to cover him, with much trepidation, staying on his cell phone for the sickle cell service. But I consider that and covering Amy Langston one long weekend for ASH, for transplant, my two greatest career honors. Now, of course, they wised up, and now Dr. Langston gets Dr. O'Regan to cover the transplant service. The National Association of Public Hospitals and Health Systems Safety Net System awarded him the Clinician of the Year Award in 2000 and 2002. He's been a finalist for the Atlanta Business Chronicle Healthcare Hero in 1998 and 2003, which makes me wonder what they're smoking there, because I can't think of anyone else who's a greater healthcare hero. And he has been honored, and deservedly so, with a special Senate resolution from the Georgia General Assembly in 2006. So I'm going to ask Dr. O'Regan, who has been an exemplary successor to Dr. O'Regan, to Dr. Ekman, and I might say, of course, as with all things with Jim, Dr. Ekman's hand-picked successor as the fellowship director to talk a little bit about his educational accomplishments.
Thank you, Sadler. It's my honor to be here as well, to honor Jim. So I took over the fellowship from him in 2006, but we'd actually worked very closely on the fellowship beforehand, and certainly very big shoes to fill. And I just wanted to show a couple of slides just illustrating, not only is he so fantastic in terms of his benign hematology skills and sickle cell skills, but he really is, I would say, the best educator that we have in the department, and I'll tell you why I said that in a second. So his teaching career actually goes back to when he was in Minnesota, because he was actually chief resident at the University of Minnesota VA in 1973. Then came to Emory's. I'm going to show you his numerous teaching awards, but he was the Hematology Oncology Fellowship Program Director for 7 years, from 1999 to 2006. And during that time, he mentored 50 fellows who are all in various practices throughout the country, and I know we're all still very grateful to him for his education. In fact, I know some of them are going to come in throughout the day today. In 2000, he got the Golden Apple Award for Excellence in Teaching at Grady, and also, as I think Bill Ely mentioned earlier, he was named to be the Dean's Outstanding Teacher Award in 2001. In 2002, we established we'd established a teaching award in his name, and this was really to honor his commitment to teaching, and he was the first recipient and the second recipient of the teaching award. And let me just say that, I get the opportunity to review what the fellows say about the faculty every year, and Jim is the only faculty member we have who scores 5 across the board in every single competency. We just don't have any other faculty member like that. And particularly because he actually teaches a lot of the fellows because of them being in the clinic with him, because sometimes you only have 1 or 2 assessments. He usually has about 8 evaluations, and they're all 5s across the board, which is the highest one you can get. And that's why I think he really is our top teacher throughout the faculty. He's also been very involved with medical student teaching. He was a recipient of the Emory's M2 Student Association Award for Excellence in Teaching in 2010. And then also recipient this year of the 2013 Best M2 Professor. So he really is a teacher across the board, which I think also really speaks to his teaching skills, because personally I find it very hard to teach at all those different levels at such an unbelievably high level. So I think one of the best educators, if not the best, that we have in the department right now, and we're going to miss that, but I'm sure he'll still be teaching all the fellows from afar. So thank you, Jim.
Thank you, Ruth. So Ruth and I have been lucky to work with Jim for 11 and 12 years respectively. We thought it was perfect that the first speaker is actually the person who's worked closely with him the longest. And Allan Platt really was arguably Jim's first real recruit. They started a partnership that set up way before there was all the discussion of the 24-hour home for the patient. This center at Grady became the 24-hour medical home for sickle cell patients. And nobody knows the history of the Sickle Center better than Allan Platt. Allan Platt is an Emory graduate through and through. He worked side by side with Jim to build this remarkable sickle cell center. And you're going to see the handwork of a great man through Allan's description of our Sickle Center, its history, its potential, its power for patients, its power for residents, and the impact it's had on literally thousands of lives. So Allan, please welcome Allan Platt.
Can you see that?
You're up there, but I don't see it. Minimize, just close that.
Did you lose it?
Step away from the computer.
I don't see it.
Yeah, we must have lost it when we were making all the changes. Just a second, we'll get it real quick here.
I do have a plan B.
We'll make it. easier if you go ahead and just run it off.
Do you want to just run it off?
No, it won't work. It'll probably, we'll get it. Just take a second here.
Awesome. Thank you.
Good morning. Happy Saturday. The first piece of equipment we bought was an IBM PC. It's now a relic, but had to put Jim in an office and close the door and make him write. And we had an old IBM PC, so he's been a tech wizard ever since. Well, this is Grady. Everybody's driven past it, seen it. It's that monster beast downtown, and this was one of the first articles, Life Under the Sickle, is one of the first transplants done that was a cure. So it's been an amazing ride. I'm going to give you 20 years and 20 minutes. How's that? All right, fasten your seatbelts. I don't know if anybody here trained at Grady prior to the center, but there was an old emergency, the Grady emergency room was split into two parts. Well, really there are 5 emergency rooms, but one was the MEC, medical emergency, and across the hall was the surgical emergency. So if you're bleeding out on the floor, you went to the right. And if you had anything else, you went to the medical, and they tried to figure it out. And sometimes there was crosstalk in between. But what happened with sickle cell patients is they got triaged by a clerk. They went into the back room at the very end of the hall, put in the very last room, and had the lowliest intern who had just started that night take care of them. And can we say care was pretty abysmal, because people didn't know what to do. Pain medicine flourished. Everybody got handfuls of Demerol and were sent home. And that's the way it was prior to '84. I trained in there, and I saw what happened, and there was the asthma room and the sickle room in the back of the old MEC. There was erratic care, no continuity, poor pain, can we say bad pain, no pain management, okay. Many hospitalizations, all kinds of ER visits, complaints, 2 or 3 or 4 a day, long waits for care, no comprehensive care, and very high cost, but Grady wasn't tracking anyway. So what do you do with all that? And again, you need to have the right mix. Right now, the Sickle Cell Center is kind of the envy of many cities, and we get calls to say, how do we do this? And so when we go, I say, well, you need to bake a cake, and you need to have the right ingredients. And it's all about what you put in the cake. But first of all, you need a medical champion. And it wasn't until Jim Ekman came to Atlanta, saw the need, and said, he had a radical idea. Why don't we do something different? You need to have a parent-patient community activist. Every city needs one, okay, and we have one here. You need a willing healthcare facility. Well, Grady was always willing. They were always showing me the money, Glad to help you, but we have no money for this. So funding was a big issue. And then you got to have a dedicated staff, and I believe you got to pray about it, man, because this thing will not happen without divine intervention, especially at Grady. Well, the medical champion was Jim Ekman. I mean, it was, you need to have somebody who knows what they're doing. And he came to Grady and was running a 1-day-a-week clinic for basically trying to do some primary care for the sickle cell patients. He's a medical educator. He knows politics well. He knows how to reach out to those who don't understand medicine and help them understand medicine and help them fund medicine. So that was amazing. He had to negotiate with the medical ER, which was kind of a Wild West, if you will, and try and negotiate better care for the patients. He had to have research interests, because again, everything is undergirded with research. He needed to fundraise, because how many how many go into sickle cell to get rich? I don't see any hands up. Okay, there's no money. If you're thinking about this, can I just tell you right now, there is no money in sickle cell research, fundraising. So anyway, network with NIH and other centers. So that's the right mix right there. You need a community activist, and we had one named Berutha Harper, and she wanted something better for sickle patients, and she and Jim bonded. I think she adopted Jim as just family, and so they trusted each other, and she would get out in the community to help fundraise and get the community rally behind this. And she has a son with sickle cell who's now married, doing well, working in Atlanta. really, I think, because of what happened at Grady. But she's connected to the community. She knew how to get public relations. She knew how to get politicians to listen. And there's a backstory to that anyway. She's a good speaker, teacher, and fundraiser. So she bonded with Jim. That's Danny Glover. That's not Jim up there. Danny Glover came through and said, wow, what a wonderful place, but he left no money. Anyway. All right. You need a willing healthcare facility. This was Grady. I mean, and there was an administrator, Phil Lamson, who really helped out he heard the vision and he bought it, but again, there was no money at Grady. Maybe a little space, but the center that Jim was formulating had to be in the hospital because people come in sick and they need acute care and they needed specialty care, so it couldn't be freestanding, it couldn't be outside the hospital, and really Grady had the most open access for the whole city, so it had to be Grady. That's where all the patients came. So again, he was the inside man trying to make things work inside Grady, and so that's Phil Lamson up there. Then you need a dedicated staff. My gosh, this is how I got recruited. I was getting ready to leave Grady. I was so frustrated with Grady. I'd spent 5 years as triage man. Anybody know what triage man is? I talked to everybody who could walk in the front door of Grady and decide what clinic they went to. It is more blessed to give than to receive. All right, that means everybody I sent patients to, they hated me because I would fill their clinic with people. And I was getting burned up. It was a great job. I learned a lot, but, I met with Phil Lamson came to me and said, would you meet with this Dr. Jim Ekman? Didn't know much about him. He said, well, I have this idea. And I thought he's either crazy or brilliant. But he was going to start a center, 24-hour care at Grady, and run it with mid-level PAs. Nurse practitioners, and this is, I was a PA then, and this was new. I was only about one of 6 PAs there, and he said, well, we're going to run it with PAs, and we're going to run 24 hours in emergency care. This intrigued me. I mean, it really tried to say, well, let me think about this. And it was the best move I ever made to say, yes, I'll embark on this. So we started to think this through. So we started by, again, formulating how would we do this. We got to get money, everything else, and to put together a whole team that would take care of the whole person from birth to death. Well, let's see. Where'd the money come from? Can we say one mom fired up can help you? All right? The Berutha incident. One patient came to the MEC, that horrible place, with chest pain, sickle cell patient, one of the beloved of the parent-patient group. She got put in that back room, left alone, Demerol for pain. She came in with chest pain. She really didn't have sickle crisis. She was having an MI. And nobody took the time to say, and take a good history. Oh, she's sickle cell, that's her pain. And she literally died of an MI. And it rose such a uproar in the sickle community. This mom said, let's go have a protest march. We're going to protest at the Capitol to have Grady start a new clinic because this is awful. So she called all her parents and friends and said, get down to the Capitol. That's just down from Grady, the big gold dome. Everybody know what I'm talking about? She called them all. They said, well, I'll be there. She did all the signs, and the signs were things like Grady kills sickle cell patients. And they were going to march. Okay, so she got down there. It was 3 o'clock in the afternoon. It was like a weekday. She got down there, and nobody showed up. She was there with her signs. And none of her parents showed up because they all were working, doing other things. Nobody showed up. So she just sat down and she said, I just sat down and cried, because she was just anguished. And at the Capitol, there's a whole bunch of school children get brought up and they park the yellow buses right in front of the state Capitol while the kids go in the museum. And this big old white burly bus driver came up and said, well, why are you crying, ma'am? And she said, well, I was going to have a protest march and nobody showed up. Well, what's this sickle cell stuff you got here? And she explained what sickle cell was. And he said, well, me and my boys, we're just waiting for the school children. How about we carry your signs for you? And the big old white burly bus driver started carrying these signs that say, Grady kills sickle cell patients in front of the Capitol, and they started marching. No joke. And the word got in on the floor. The head of the Black Caucus came out and said, "You got to stop this. This is awful." And I think it was Douglas Dean, head of the Black Caucus, came out and said, "Ma'am, if you'll stop this march, I'll listen to you. Come inside my office and I will help you." And that's literally how the beginning of the genesis of money funded from the state to Grady to fund this center. So we call them the angelic bus drivers in South Georgia. Don't know who they were, but they were on time and on point. Now what happened that one day is Grady was supposed to get $500,000, a lot of money in that day. Somebody misplaced the decimal point in government. Now that doesn't happen, right? And $50,000 came the first year, but they fixed it the next year. And this is Berutha with her son. It's kind of a bad, I don't know if you can see, but she got on the AJC newspaper to, again, publicize sickle cell to Atlanta, that Grady needed a sickle cell center. And this is her talking, again, to know. And again, Jim is there, but all the legislators got on board. Well, the state came up to with $500,000. That's unheard of. Most places can't get that kind of funding. So staff was hired. Grady said, "Okay, now you got money, we'll give you space." They gave us an old newborn nursery that had been closed down and said, "Make it a sickle cell center." Can we renovate that? No. And so we had to scrub the floors, paint the walls. Basically, literally, our team building effort was renovate. Okay, so you've heard of House Hunters. We got the 9B floor. We painted, scraped, cleaned, put plants in it, made it nice. We bought a PC, that's the first thing we did, an IBM, and we started collecting data. We did our protocols. We all went under intensive training under Jim Ekman. He taught us how to manage acute pain in all the episodes, because we knew nothing. So we hired 6 PAs and just technicians to run the clinic 24/7. Radical thing back in that day. Again, this was the 9B center. It kind of doesn't look like a newborn nursery anymore. We had plants. We were the envy of the whole upstairs because we actually had living plants. I don't think we bootlegged them in. And this is some of the scenes of that back in the day. That's at the center. You see that little PC on the desk? We made all the staff data entry. We actually developed a Sickle EMR before it was EMR, and we started collecting patient data. And that saved us so many times when Grady said, "You need to close." So what happened when we started out? The emergency room lied to us. How many know ERs lie? Okay. They said, "Oh, you'll just have a few patients, no worry. It's only 25. How could that fill you up?" We only had a few beds. And they said, "Well, those 25 patients came to visit us every 48 hours. And we saw them over and over and over and over." Basically, it was Demerol. They had been basically placed on Demerol all their lives, high levels of Demerol. And we were understaffed. At some point, we had 6 beds. We would have 24 patients, being treated at a time. So we had people sitting in chairs on the, we'd pull out the office chair, sit here, and we'd do what we could do. So we really were unpredicted. And again, build it, people will come. I don't know if you noticed, but the word got out. There's a center at Grady that treats sickle cell. People came for miles and started coming. So again, people heard there was something better. Well, this is just to show you kind of a famous graph, but for 1 year, these are the active adults. And the green bar way down here was, if you look at the green bar, that's the number of patients. There are 271 patients in that green bar that had 0 pain crises per year. Well, that was a myth buster. You mean they don't have pain all the time? No. Figured that out. 237 only had like 1 to 6 crises a year. We had 28 patients that accounted for 2,767 visits in a year. Okay, well that's what most ERs see. That's the ones that gave everybody kind of the reputation. And so we had a closed audience. We kind of saw that. Again, to deal with that, we had to just basically keep things rolling. The medical directors wouldn't back us up at that time to do any intervention. They should just keep quiet, please. And that's all we could do, is just maintain. Again, we had a multidisciplinary team. That's our whole crew. We had PAs, NPs, MDs as the clinical providers, newborn screening coordinator, RNs to be case managers, teachers, social work. Again, having social work to deal with the psychosocial issues, which are enormous. We even have a psychiatry nurse specialist because, again, the psychiatric needs are enormous. We had everything from techs to clerical, even a vocational rehab specialist. So, again, the multimodal medical home, before it was vogue, was done by Jim Ekman. okay? And again, this is what patients really need, is support from all angles. In the 24-hour center, again, we wouldn't see the kids. You had to be 15 years or older, that's Grady rules, or if you were pregnant, Grady said, okay, now you're an adult, go, come on in. But it was basically Jim trained us as PAs to be his eyes, his ears, and his hands to take care of the patients 24/7. He was on call 24/7. Now, we didn't abuse that, okay? We tried to protect Jim because we knew we wanted him alive, we didn't want to kill him. So we would try and channel Jim for every patient and take care of patients till he got in the morning and basically do that. But we had residents to back us up at night, but you know, nobody knew, we always knew you had our back. And to us, that was comforting to know if things went south, we could pick up the phone, call him, he'd tell us what to do. We had problem-specific guidelines. We actually wrote down, we locked him in an office and made him type on that little PC all the guidelines. So we had there was no textbook to help. He wrote the textbook for us to use. And those guidelines were actually published. We put them out. And then nobody wanted to print them. We did it with a grant because they said, sickle cell, we don't make money on that. Oh, you know, have we heard that a lot? So that's another story. Aggressive pain, fluid management, we would hit the ground running. Where else in an ER could you come in and be seen in 15 minutes with an IV running and pain medicine flowing and have a good head-to-toe physical? I don't get that, you know, when I go to ERs. So it was amazing care in a dedicated setting with people who knew what they were doing, knew the patients, and you know, that's the radical thing that nobody's been able to duplicate. We would treat for 8 hours, then decide to admit that 8 hours is golden. We found over 20, 30 years now that at 8 hours, if you can't break the crisis, they need to be admitted. And that's just no question asked. They are going to be in the hospital for about 2 to 3 days, or something complicated is going on. So most people got better in the 8 hours of aggressive treatment. And then we had our own medical record system. We even took down the Grady servers. That was another thing. So we had really good stuff. We had great equipment with grant money. And our treatment of pain was stepwise, multimodal. We hit the pain multiple ways. I believe I learned everything about pain management from Jim Ekman because, again, nobody in pain management knew what to do with sickle cell pain. He understood chronic pain versus acute pain and how to manage both. And it's an art. And again, we learned from the art. We had a quiet environment. We had a nice area. It was all where patients could come and trust us, and they would come early before their pain got too out of hand so we could get ahead of it and get them better. So we used multiple agents to hit the pain. 10 years of data. Again, this is pretty amazing stuff. 20,968 pain episodes in adults. I think I saw half of that. Anyway, 1,000 patients, again, over 15. Oldest patient, 82. There's a radical thought, too. Older patients, yes. Again, we did the pain assessment using visual analog scales. We'd admit them if they had any complications whatsoever. If they returned within 48 hours or we couldn't get them better than 8 hours. Over that time, we got 80% better in our ER to go home. Go home. And patients really did want to go home. They didn't want to be admitted. Well, this saves money when you save admissions. How many know admissions are where the money is? Huge a cost once you come in the hospital. So if you can get somebody better, have them go home and they would not return, and they were well. That was a big event. And nobody's been able to kind of duplicate that except at a couple of day hospitals around the country. So what happened? Again, admissions dropped. We followed 166 of the same people that opened our doors all the way through 10 years, and you see the admission rate steadily declining. This was patients doing better. Though they were not having as many pain episodes, we could do the primary care, we would intervene early, and basically keep them out of the hospital doing well. Even their acute care visits fell. So emergency room visits, if you will. Total admissions, all active patients. High level when we first started, all the way down to it's been baseline, down to 0.5 per person per year. Again, over time, looking at ER visits versus admissions, you saw a dramatic decrease when case management was instituted, a multimodal approach, the medical home established, all those services provided for patients. This could be modeled in many chronic diseases to save money. I mean, you take congestive heart failure, you can take asthma, you can take diabetes. Any of those, you just plug in the disease, do the model, this might work. Okay, kind of Food for thought. Comprehensive, we even got on the cover of Nurses. All right. Okay, yeah, that was... Comprehensive primary care, again, we had adult team, pediatric team, hydria monitor, leg ulcer care, all those are the issues patients face on a daily basis. And all those were supported Monday through Friday, but the acute care was going on 24/7 in the same area with the same staff. Again, that's a radical thought, but the patients got to know us in both settings, both genres. Again, this was 24-hour urgent care, and there was a cost, basically this has been tried to be modeled, but basically most cities have a day clinic now. They don't operate 24/7. In Chicago, Boston, Baltimore, down in South Florida. Hydria came into being. Hydria has revolutionized patient lives, and Jim brought the trial to the center and was an integral part in this drug trial that actually improves lives and improves their lifespan. And again, so having the center, having our database brought research to Atlanta. And not only that, it brought a whole NIH grant for several years. So all the data, all what Jim established, he established great clinical care, great data, great medical home. Now let's do the research. And it's kind of reverse of what most people do. They get the money, do the research, but there's no clinical care. And when the grant goes away, what happens? All the clinical care implodes. He had a strong foundation of clinical care, then built the research. So regardless of research dollars, the good care would still go on. Again, that's a radical thought there. Again, newborn screening. Jim championed newborn screening, not only in Georgia. Can we say we were one of the last states? Oh dear, I know. But it championed it all over the Southeast, all over the nation, and now international. In England and other places, people are calling him to come say, should we do this or not? Again, saving kids' lives. And I can't imagine the number of kids put on penicillin and given all the immunizations that have saved, that basically are living today because of this public health institute. So, is he interned? Yes. But can you say pediatrics at heart? Yes. Okay. And a geneticist, a dual appointment. Again, saving kids' lives. STOP study even. He brought the STOP study to Grady. That was, again, to detect strokes using transcranial Doppler ultrasound. How many kids have been prevented from having their first stroke because of this study? Again, Bob Adams, it was at MCG, but Grady was a big part in this whole multi-center trial. And again, it was a collaborative effort. So the research was fabulous. Again, nobody would publish our book. So what do you do when you have a book that you want to get out for no money? We went on the web, okay? And we actually, I got David Archer, I know he's in the audience, he helped me set up a bootleg website under pediatrics. We just put the protocol book up on the website and gave it away, and we kept it very quiet. Nobody knew, but this was an Emory little website, Sickle Cell Information Center, and we kept it go live for years, and then people kept sending us stories and news, so we actually built a whole information site for the world for no money. It cost us $0. And that website is still up. It is still getting over 100,000 basically new visitors a year. So we're actually educating the world without ever leaving our seat. And we have a listserv of over 45,000 people around the world who get a monthly newsletter, and Jim helps author that. So again, this is all of Jim's brain on the web to help people. This was all given away for no money. Can we say nothing is ever earned from this? So it's a giving back. Again, how much did it take to run the center? $3 million. Where did that come from? $1 million from the state, $2 million from billing. Our emergency care underwrote the primary care, of which you get no money. And again, this funded a huge number, 36 FTEs, 4 MDs, 6 PAs, RNs, clinical assistants, all of that. We reduced admissions down to 0.5 per year. When we did the calculations, this equates to $12 million in saving to the state per year. So whenever they come to chop us or say, you don't need the money, we said, look what will happen when you take all this away. They said, thank you very much. Your check's in the mail. Got to keep the dollars, okay? Again, and patient satisfaction is awesome. It's the center for, again, we got modeled by JACO for pain management. Grady said, take them to sickle cell. We always got the tours, and it was always the inspectors. And basically, they loved what we did for pain management. It was a model. They actually did books and videos on that. So what does all this mean? The life expectancy of patient there is in that pink curve.
And you go all the way back into where sickle cell disease was identified back in 1910 with Herrick in the first article. But then you come up to the, where Congress passed the National Sickle Cell Disease Act in the 70s. But then the newborn screening programs came in. See, the life curve is going straight up. Straight up. And do we have an endpoint? I don't think so. With Hydrea coming on board, we can expect our patients to have basically a normal lifespan, and that is incredible. We're having cures with bone marrow transplant. All that was brought to Atlanta because of one center, one vision, one man who had this crazy idea to do something better for the patient. And I think it's caused a science explosion here in Atlanta. I think we're an epicenter. People move here just for the services. You ask them, and they say, why Atlanta? Well, because I've heard of all of what you do here for sickle cell. And it's brought all the resources here that you see, and it's been amazing. So I attribute that to Jim's vision, and I think most people would. I think it's hope for everybody, early prevention, treatment, screening, better education, better treatment, a cure for all. I think it's on our horizon with the transplants and gene therapy. Jim actually co-authored the book that is the bestseller patient education book, Hope and Destiny. And his wisdom has now been, I translate from medicalese into patient, and this is what patients read so they can be experts in their care. And this has gone worldwide. So to me, all of that is going out in several different genres, and the impact will be there for years. So can I say it started with a dream, and the dream lives. I know he's retiring, but the dream goes on, and it's impacting people daily. Thank you.
Okay. I see Danny. So Danny Armstrong really needs no introduction. If you know anything